Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everybody, and welcome back to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. We've got a great lineup of speakers to kick off this year, and the TMI has several other educational offerings for vets in practice, both online and hands-on, and you can check those out at CSU Vet CE. Today, we are joined by three well-known veterinary gastroenterologists that love endoscopy and will share their 100 collective years of experience in endoscopically removing gastrointestinal foreign bodies. Our speakers are Dr. Mike Leib, Professor Emeritus from Virginia Maryland Regional College of Veterinary Medicine at Virginia Tech University, Dr. Mike Matz, who is in private specialty practice in Tucson, Arizona, and Dr. David Tweed, who is Professor Emeritus from Colorado State University. So without further delay, I will pass it to our first speaker, Dr. Tweed.
So what we're going to do is talk about our experience in removing gastrointestinal foreign bodies. You might want to retitle this lecture as Three Old Guys Talking About GI Foreign Body Removal. What we're going to do is talk a little bit about equipment, techniques, tips, and we're going to give a lot of case examples. And I'm going to kind of start things off by talking about some of the endoscopic equipment. And one of the things that you're going to need are various types of graspers. Up at the far left are the rat tooth graspers. They have a very good grasping at the very end of the forceps. And this is pretty much universal, good for getting coins, getting a hold of small foreign bodies and so forth. There are other iterations of these graspers. Here's one that's called an alligator jaw type grasper. Not one of my choices. I like the rat tooth end. You can get rat tooth with alligator jaws. Sometimes they're called pelican graspers, duckbill graspers, and so forth. I like the one on the far right because the grasper length is quite long and it helps me get a hold of good foreign bodies. There also are rubber tip graspers. I wouldn't recommend those. They're for getting out needles and thread. They're not very useful. There's a grasper that I found that's called a Raptor grasper. It's made by a company, Steris. It looks pretty darn aggressive, and I'd like to try that one out. I haven't tried that one personally. You also have your biopsy forceps, and here's an alligator jaw or serrated biopsy forceps. I don't recommend using biopsy forceps because the cups are so small. And if you have non-disposable biopsy forceps, it's going to dull your biopsy forceps. If you have disposable and you got an old pair, certainly you might keep them around. It may help you on some cases. Also available are endoscopic prong graspers, and these have these prongs come in 2, 3, or 4 prongs. They have sharp little tips at the end, and when you grab they're very good for cloth type material. When you grab a hold of those and you pull the prong into the shaft, you get a really tight grasp. They're remarkably strong. Shown here at the bottom is Stor's 2-prong grasper. I like this one because it does have the rat tooth end on the grasper, and they work very well for foreign bodies as well. You're also going to need some snares, baskets, or nets. And I would probably have at least a snare and a basket. Shown on the left is a polypectomy snare. These are disposable, relatively inexpensive. They're used for removing polyps, can be hooked up to electrocoagulation. And They're good sometimes for lassoing various types of foreign bodies. And then there are baskets, and there are baskets that have 3 wires, 4 wires, 6 wires. Don't get a 3-wire basket. And also the baskets are not all the same. You definitely want to find a basket that will retain memory of the shape of the wires, because when you put that down into the stomach to remove the foreign body, you want that basket to pop into normal shape. Some of these will have the ability to rotate the basket or the snare, and this is done on the handpiece. That's a nice thing to have to try to help you grab some of your foreign bodies. There's also what's referred to as the Roth net on the far right. This Roth net basically is a snare with a net where you can lasso various types of foreign bodies, especially smooth foreign bodies. One of a basket that I think is imperative to have, and I call it the golf ball basket. It's very large. It's made by Stores. It's 10 by 14 centimeter basket. It has 6 wires. And this is what I use to remove golf balls. We had one case that had 5 golf balls in the stomach, and we could whip those out in no time. So you need baskets, snares, in removing your foreign bodies. What I want to do is talk a little bit about esophageal foreign bodies, specifically bones. They're the most common foreign body that we generally will see. And prompt removal is really important with an esophageal foreign body. At our university, we say the sun should never set on an esophageal foreign body. We'll come in the middle of the night. We'll take out foreign bodies anytime, any day. And the faster you get those out, the less chance you have for perforation and potential stricture or diverticulum formation. With bones, they often, if they've been in the esophagus for a period of time, they will erode into the esophageal wall. And sometimes you have to grab a hold of it and twist it before you can actually pull it out through the esophagus. If I can't pull a bone out, and I can push it into the stomach, I will do that. Bones are usually rapidly digested by the acid in the stomach. I never go into the stomach to remove a bone foreign body. One of the things that we always warn our anesthetists is when we're dealing with esophageal foreign bodies, where there is a potential possible perforation of the esophagus, as you insufflate the esophagus, you can create a tension pneumothorax. And that's happened to me on several occasions. And these animals are in really critical shape. And in our endoscopy room, we have an emergency chest tapping setup for those patients that have or may develop a tension pneumothorax. So removing esophageal foreign bodies, there are a number of techniques that have been described. In the literature, they talk about actually using a Foley catheter, passing it past the bone foreign body, blowing up the 30 cc bulb, and then pulling the foreign body out through the esophagus. You can use flexible GI endoscopes with baskets or graspers. On the right here is a video removing a wishbone, a chicken bone. We're using a 2-prong type grasper for removing that. And as you can see, what you have to do is get that bone moved out for where it has ulcerated into the wall, so then you can be effective in removing it. There are available rigid graspers. They are very good for bones. On the far right here is a grasper shown that was sold by Jorgensen's lab. It's 25 centimeters in length. That's about 11 inches. Oftentimes that's too short to reach a bone. If you do any laparoscopy at all, you can use your Babcock grasping forceps from laparoscopy. They're a little bit longer. They have really good sharp teeth as well. What I like to use for bones, for large bones in the esophagus, is what I call the overtube technique and a rigid grasper technique. And essentially, I'll take a rigid esophageal scope, pass it down to the foreign body, then take my strong grasping forceps down to the foreign body, grab a hold of it, pull it up to the rigid tube, and then pull everything out together. That rigid tube often will help in dilating the esophagus. Shown up here in the upper right is an old esophageal scope that was an antique when I got to Colorado State University, probably in the 1950s or 60s. I don't use the light bulb at the end, but I do use that for passing down to grab a hold of large foreign bodies. Also down at the bottom is a foreign body grasper. This is one that I actually talked the Storrs company into developing. It's really nice in the fact that it's 70 centimeters long. It's very sturdy. It has really sharp teeth, and the jaws will open up to about 3 centimeters in diameter. In the catalog, they call it the Tweed foreign body retriever. And I don't get a royalty on that. Maybe I should, but I use that for many, many foreign bodies. And so this just shows that foreign body grasper in one of my old rigid tubes. You can sometimes find old esophageal scopes. Sometimes you can even use a human sigmoidoscope to go down to some of those foreign bodies. So shown here is a bone foreign body. We've got the rigid tube that we've passed down to the foreign body. I've got a prong grasper shown here. I've got my endoscope also within the rigid tube. I twist the foreign body out, pull it up to the rigid tube, and then pull out. And here I'm trying to pull it right around the larynx and pull it out. You always want to go back and reassess where you've removed your foreign body and look for the amount of damage. And you can see the 2 areas of ulceration where that bone had sat in that esophagus. So again, the sooner you get those out, the better it is. This is also showing using that rigid grasper, but not using the over tube, but actually going down adjacent to the endoscope, grabbing the bone. You can see how those sharp teeth really get into that bone, and you're able to pull that out. And so sometimes we'll just pass it along beside our endoscope. And then as you go back here and you can look in this center view, the areas of ulceration in the esophagus from that bone foreign body. I generally get very concerned if I see transmucosal ulceration going into the submucosa greater than 180 degrees circumferentially around the esophageal lumen. I think those are the cases that I generally warn the owners of a potential esophageal stricture formation. You can also make a homemade foreign body grasper. You can get some PVC type piping. You can purchase these polyvinyl tubes online, various diameters, various lengths. And you can actually even go to Lowe's or Home Depot, and shown on the right there is what they call the cat's paw lighted pickup tool. I think it runs around $20, $21. It has 4 prongs, and sometimes that will be helpful in removing some of your foreign bodies as well. What about fish hooks? And if you have a fish hook in the esophagus, and usually they're always attached to a line, and usually what happens is the owner pulls the line and sets the hook in the esophagus. And you can use those strong foreign body graspers and go down and grab that fish hook. So what you'll do is you'll grab a hold of the fish hook and then push it out of the esophagus and then pull it out. I don't really worry about damaging or damage to the esophagus. There were studies that were done that some surgeons cut 1 centimeter holes in the esophagus, and they spontaneously heal quite nicely without problems. If you have a rigid tube, your esophageal tube and you have a line, what you can do is you can take that line, run it through that rigid tube, and then pass your rigid tube through the line down to your fish hook. And then what you can do is use that rigid tube to push out the fish hook. And then as you push out the fish hook, you apply a little pressure to the line. That kind of pulls the fish hook into your rigid tube, and then you can pull it out thereafter. So that's sometimes what I will do when I'm trying to remove fish hooks. So as far as gastric foreign bodies, as you know, dogs will eat almost everything. Here was a little collection that I had of various types of gastric foreign bodies. Right up here in the center is a cat that I took out of a dog, and coins and various other things as far as gastric foreign bodies. One of the biggest problems I find in removing gastric foreign bodies is, especially when I'm using the small forceps, grasping forceps, is they fall off as I try to pull them through the lower esophageal sphincter. And so I think there are several things that you can do. One of the things is very definitely have very strong forceps to grab a hold of that foreign body to pull it through the lower esophageal sphincter. Certainly baskets or snares, you really have a good hold on them, and oftentimes you can very easily pull them through the distal esophageal sphincter. Sometimes I will take my big, long, rigid grasping forceps, pass it down through the esophagus all the way down into the stomach, and sometimes I can grab a hold of a foreign body in the stomach, usually in the fundic region. In human medicine, they often use what they call the over tube technique, and this is where you pass your endoscope through a larger tube where you can grab a hold of your foreign body, pull your foreign body into the tube, and then pull your foreign body and your over tube out through the esophagus. Also available are foreign body retrieval hoods, as shown here on the lower left. And these retrieval hoods fit on your endoscope. They're little rubber hoods that fit on your endoscope. You can tape them on or rubber band them on. The hood is folded back as you go down into the stomach. As you grab the foreign body, as shown here in this video, grabbing a fish hook on a fish line. And as you pull your endoscope back to the lower esophageal sphincter and through the sphincter, that hood folds over the foreign body. It helps that foreign body get through that distal esophageal sphincter, and then you can pull it up through the esophagus without further damage. These foreign body hood protectors, if you buy it from a human company, 10 hood protectors, these little plastic things run $450, $45 a hood. There is a veterinary version, which is exactly the same thing, from ESS that runs $250 for your foreign body hood protector, so about $25 a piece. You have to buy them in numbers of 10. I just went on the other day online. I found outdated foreign body hood protectors for $15 for 10 and $4 shipping. So that's something that I would definitely have when I'm trying to remove various types of foreign bodies. You can also make your DIY foreign body hood protector. You can take a surgical glove, cut it off at the wrist, tape it onto your endoscope, flip it back, pass your endoscope down, grab your foreign body. The hood will then go over the foreign body as you go through the LES. I've even seen online people using condoms for the same purpose. As far as some of your foreign bodies, one of the things for round foreign bodies is to use a basket. And you want to use at least a 4-pronged basket. You don't want to use a 3-pronged basket. I don't like those at all. The trick is to get the foreign body in the center of the basket. Once you get the foreign body in the center of the basket. Then you're going to close down the basket. And one of the tricks in doing that is that you want the basket tubing end on the foreign body where you want the basket to tighten down on. So where you put that end is where the basket will come together and tighten down. Once you've been able to grab your foreign body, and I'll do this for cloth material, little stones as shown in this video. Once you get a good hold on it, usually those you can easily pull through the lower esophageal sphincter and into the esophagus. So here we are backing it up. And in this particular case, we had to put quite a bit of pressure to get this through the distal esophageal sphincter. So I'm right up at the sphincter now. I'm pulling quite hard. I'm pulling and pulling, and then pop, the foreign body gets into the esophagus, and then usually you can very easily retrieve it from there. I guess I have one final trick from Tweed, and that is sometimes consider using the needle and thread technique. And essentially, if you have a foreign body that has an eye within it, you can go down and put your nylon fish line through that eye, bring it back out, and then pull it through out of the stomach and through the esophagus. So what I'll do is I'll get my heavy duty fish line, I tie a knot in it, I put my grasping forceps through the endoscope, open up my grasping forceps, grab a hold of the loop in the fish line, I go down with the fish line along the side of the endoscope. I take my grasping forceps, try to put it through the eye of the foreign body, grab it on the other side with my grasping forceps and pull the line out. And sometimes that's a good way of getting out some of those foreign bodies. So that's what I was going to talk about. And so I don't know if we have any questions or any comments from one of the other Michaels.
We do have a few questions. First one, what percentage of esophageal perforations with pneumothorax end up requiring surgery?
Basically, if I ever have a dog that does develop a tension pneumothorax, and the reason they get that is you're insufflating, the air goes in, it can't escape out. I usually will put in a chest drain, and I never take them to surgery. And usually those spontaneously heal up. And obviously I put them on antibiotics.
Okay. Next question. My clinic has just purchased an endoscope. Do you have advice on ways to practice using the different tools before we need to go fishing in a live patient?
I think there are several things that you can do. One of which is you can just practice putting foreign bodies on the table or in a tube and go down with your grasping forceps and try different techniques.
Okay. Next question. Do you have any suggestions for Roth nets that have a bit of a pouch that can scoop up the foreign body? Ours are pretty flat, and we usually get frustrated using them and switch to a basket.
Yeah, you know, I don't use a lot of Roth nets, and I think one of my complaints is that the net is not big enough to get some of the foreign bodies that I want to try to retrieve. Maybe the mics have a comments in regards to that.
Yeah, I would just say that they're best for small foreign bodies, small slippery foreign bodies. If they're too big, I agree. The net is not concave enough to grab the foreign body, and that's because that net has to pull into the PE tubing in order to be delivered through the biopsy channel. And so there's a size limitations, and that's why they stay relatively flat.
Okay. Next question, Dave. Do you try to fast your patients first, or you go in right away?
food in the stomach is really difficult to find foreign bodies. And if I have a foreign body that's in the stomach and a stomach full of food, and I don't think that foreign body is going to pass on down and cause a small intestinal obstruction, or that foreign body is, such that maybe it's a needle on a thread or things such as that, which I might go for, I might just wait for 12 to 24 hours, till the next day for the stomach to empty to go down and be able to get the foreign body.
Okay. When do you recommend sucralfate and or acid suppressants post-procedure?
If I have severe esophagitis, I usually will put them on a PPI. And if I have severe esophageal ulceration, I may use some sucralfate. Sometimes if I'm really worried about maybe some reflux, especially if it's right down at the distal esophageal sphincter, I may even put them on some cisapride as well.
Okay. A couple of similar questions here are asking about esophagostomy tubes or gastroscopy tubes, gastrotomy tubes, I should say, or what you recommend for post-removal feeding, especially if you're concerned about the level of esophageal damage.
With an esophageal tube, going into the esophagus, that is going to heal up very, very rapidly. I generally pull my esophageal tube. I usually take a little betadine ointment on a 4x4, put it over the area, and let it close up with time. I generally will go ahead and feed these animals afterwards. Same thing with a gastrotomy feeding tube as well. I often will put a stitch in the skin just so you don't have gastric contents coming out through the fistula of the gastrotomy feeding tube.
All right. Is there a trick to twisting the esophageal foreign body to get it to dislodge?
Not really. It just, you fiddle around with it, and you may have to push it in a little bit and try turning. There's no real specific trick. If you have a good, strong pair of graspers, that's relatively easy to do.
Okay. One more. Any tips on getting the Tweed grasper to slide down the esophagus when it wants to go into the esophageal wall?
I usually haven't found that to be a problem. I usually watch it go down with my endoscope, so they go down together. One of the things that you want to do is if you're putting anything rigid down, rigid tube or whatever, you want to extend the head and neck out as straight as you possibly can to pass down the esophagus.
Okay. I think we'll cut it off there and move on to Dr. Leib.
Well, thanks, Chris, very much, and welcome everybody to my part from Blacksburg, Virginia. And I just want to start out and let everybody know that if this was just Mike and Mike doing this talk, we would have had to call it 30 years of endoscopic experience, but since we've added Tweed, we had to expand it just a little bit. So I have a few things I'd like to add to what Dr. Tweed said, and a few particular items that I've selected some cases to demonstrate. So the first thing I'd like to talk about is the importance of a forceps with really good strength. And the image that we're looking at here on your left is a pair of teenagers' underpants that was eaten by a relatively young Doberman pincer. And the interesting thing about this case is that the dog was observed eating these underpants 7 days prior to presentation. And the reason the owner waited that long was because they didn't actually see the dog eat the underwear. They saw that the underwear seemed to be lost and gone, and the dog had no clinical signs. And then the night prior to presentation, the dog vomited 15 or 20 times uncontrollably, and then was brought in. And what had happened is, being a large breed dog, the underwear probably stayed in the gastric body and the food moved back and forth, and there were no clinical signs. And when the underwear got wedged into the antral cavity of the stomach, and then down into the proximal portion of the duodenum, it created a pyloric obstruction and clinical signs. So what was exciting to me was that the owner described that this was his son's fruit of the loom underwear. And I was very excited that I would be able to, in the stomach, roll back the label, snap a few photos, and be able to sell those to Fruit of the Loom Underwear Company as a good advertising tool. And unfortunately, this pair of underpants were so tightly wedged in the antrum and the pylorus that we could not move it at all. And luckily for us, as you can see on the right, we have a rat tooth forceps that was able to get a good grasp of the underwear. And then it was extremely difficult to remove the forceps and the endoscope, but slow, gentle traction, and the underwear started to come back, and then we're able to remove it. Without a pair of forceps to give you this level of a purchase on the foreign body, it would easily drop off at the gastroesophageal sphincter. So here's the underwear, and you can see it was not impervious to gastric acid. There's quite a bit of damage here, and so it wouldn't work very well as an advertising ploy for the company. And as you can see, it was not through the loom anyway, so didn't matter. But strong purchase made a difference in this case and many other cases. So on the right side, you can see what I call the standard or smaller rat tooth. It's got the 3 interdigitating teeth that once you close this forceps, it will grasp whatever is between them very, very well. And then one of the forceps, this is, I think, a 19 millimeter rat tooth, but I call it the large rat tooth forceps. It really opens up very wide to allow you to grasp onto a larger foreign body. One thing I will mention with this type of forceps is at a point of about here all the way down, this is not a flexible portion of the forceps, but a rigid portion of the forceps. And so this forceps has to be passed with the insertion tube tip of the endoscope in a relatively straight position. If you have that deflected 45 to 90 degrees, or if you have it retroflexed at all, it will get stuck. And if you pull too hard, it will damage the biopsy channel in the endoscope. So you have to be careful with this large rat tooth forceps, but it is an excellent forceps to have available for you. The second thing I want to talk about is positioning of the endoscope and removal. Many of the small motile foreign bodies that we see, when an animal is in left lateral recumbency, which is the typical position for doing upper GI endoscopy, that foreign body, which is free to move about the stomach, will by gravity move into the cardiac region of the stomach and will only be visible in a retroflex position of the endoscope. And that makes it very difficult to pass your forceps to grab the foreign body and then remove it. So here we can see on this radiograph, there is a metal dense circular object here, which we can see in the endoscopic view was a fairly large marble. And the reason it showed up on the radiograph is that this was an older marble and it contained leaded glass. And so you're actually seeing the lead on the radiograph. Here's on the other side of the image is the endoscope coming through the gastroesophageal junction. twisting around in the stomach and then looking back on itself. So you can see attempting to remove the foreign body in this position means we kind of work backwards and upside down. It's difficult to move forceps back and forth through an endoscopic channel that is retroflexed, and difficult to grasp the foreign body. So what we need to do is reposition the animal and allow gravity to move the foreign body so it's available in front of the endoscope. We can work without a retroflex position. Just another example, 2 pieces of corn cobs remaining in this dog's stomach. This dog got into the garbage, ate a whole bunch of corn cobs, vomited corn cobs for about 7 or 10 days. The vomiting stopped. A referring veterinarian took a radiograph, and there were still 4 pieces of corn that were not coming out despite all of this vomiting. So on your left, you can see the gastroesophageal junction with the endoscope coming out, the black endoscope tube moving down. We've twisted it back on itself in a retroflex position. We can see these foreign bodies. They look like they'd be relatively easy to grasp with a 4-wire basket, or perhaps even a snare, but we're working upside down and backwards in a retroflex position, very difficult. The image on the right shows what happens when we've switched the animal from left lateral recumbency to sternal recumbency. The foreign body falls out of this region into the body of the stomach, and now it's visible directly in front of the endoscope for relatively easy retrieval. And here we can see we have a 4-wire basket around, and very easy to remove these, even though they were fairly large. Why these 4 pieces did not come out with continued vomiting, I'm not sure, but I think that can be typical sometimes. So if we look at our anatomy, on the left is a barium series in a dog that is in left lateral recumbency, as if it would be for upper GI endoscopy. And you can see the barium is moving. The esophagus will come in right about in this direction. So you can see most of the barium is pooled in this region, and that's where your modal foreign body is going to move. The image on the right is a dorsal ventral view, and you can see the barium has moved from the cardiac region of the stomach into the body right in the middle. And as the endoscope were to come in, you can see you'd be able to work right in front of yourself, making it easy to grasp. So remember your anatomy from veterinary school, move the animal. It will save a lot of time and make you more successful in removing some of these small modal foreign bodies. Dr. Tweed showed the Roth net, and you can see in this ball here that you get a little bit of purchase below the wire, but it's not as roomy as we would like, and larger foreign bodies just cannot be scooped up. But if your foreign body fits into the net, the netting makes it quite easy to tighten that wire snare down and to remove the foreign body. We do see a fair number of coins, and I agree with what Dr. Tweed said before. I find that the small rat tooth forceps, if you can grab the edge of the coin, provides really strong purchase, allowing you to take this out. You could probably get a dime and maybe a penny into a Roth net, but I think the rat tooth forceps would be best. This is kind of a gee whiz thing, because you can see the penny here, and you can clearly see the date on it, 1981. And why dates are important is because we know starting in 1983, all pennies minted were made of 95% zinc. And then the zinc in the stomach with gastric acid can solubilize, the dog can absorb the zinc, and it produces a hemolytic anemia. What some people don't realize is that zinc was added about halfway through 1982. So a 1982 penny has about a 50% chance of having zinc in it. 1981 penny has 0 chance. So why am I showing this? Besides, it's an excellent photograph of the date, is that this dog presented for hemolytic anemia. And the clinician took an abdominal radiograph, saw the presence of a coin the size of a penny, and said, this is what is causing the problem. So went down, did endoscopy, removed the penny, was quite disappointed it was a 1981 penny, and it was just a coincidence that the dog had autoimmune hemolytic anemia, had nothing to do with the penny, and unfortunately had to undergo general anesthesia and endoscopy. Not from this dog, but from other dogs to clearly show older pennies. On this row here, you can see that gastric acid just makes them nice and shiny, where the zinc containing pennies minted 1983 and excuse me, 1983 and after, you can clearly see they are getting pitted and broken up by the acid. And you can see also for our international audience out there, a Canadian nickel at the same time in this dog. Dr. Tweed showed a golf ball. Once again, they will often move into the area that requires a retroflex view of the endoscope. So you may have to apply sternal recumbency on the animal to move the ball down into the body in front of you. And then they usually can be removed by a 4 or 6 wire basket. Not all 4 wire baskets are large enough for golf balls. So you need to be careful that you have one that is large enough for the diameter of a golf ball. And you can see here the basket at the bottom is really not large enough for a golf ball. On the top is the 6 wire basket by Storz. And this obviously is very large and will enable you to grab the golf ball. Briefly want to mention some people who do not have the large baskets make their own with baby bottle liners. And you could attach fishing line to them, and these can be manipulated in the stomach, or the dog's position can be altered, and you can scoop up the large foreign body and then pull on the fishing line. And I have a reference listed here from the internet from a veterinary internist who has a very nice description on how you can make these and have them available if you think they'll be helpful in your practice. Now, one of the things that Dr. Tweed did not talk about is the size of foreign bodies. Most of the time we think if the animal swallowed it, we should be able to get it out endoscopically, but I've had a couple of instances where that has not occurred. Here's one instance. You can see foreign body on the lateral radiograph, and you can see one here on the ventral dorsal radiograph, has the shape and size of a Kong. This was a basset hound, fairly large dog, and this was a very large Kong. So you can see the outer 2 donuts of the Kong here. The inner donut, which is the largest, is in the antral cavity located here behind the angularis incisura. So this is a giant thing. How the dog swallowed it and how it got to his stomach, I'm not sure, but it was very challenging and in my hands, impossible. And maybe we can ask the other panelists if they could think of a better way of getting this out. I'm not sure that even a 6 wire basket is big enough to get this. If you could get some sort of snare around the outer smaller donut, which is what I tried to do, you might be able to orient it in that manner. There is a hole in the middle of this, and we could get, as Dr. Tweed showed, we could get his fishing line through that. The problem with that is that would pull it out transversely, and there's no way we could get that through the gastroesophageal sphincter. Here you can see it was an official Kong product. Here I am at the other end, the small end, trying to use a rat tooth to grasp the edge of the material, and all it did was to take a biopsy specimen. So very, very difficult to get out, and unfortunately, we had to decide in a short period of time that we did need the help of the surgeons, and here you can see them surgically removing it. So other panelists, do you have any ideas you think could be successful with this, or are you going to call the surgeons?
I'm going to say something I would consider that I've done with a different type of things is maybe getting a balloon, using an old esophageal, dilator. If you push it through there and then expand it into the center of that would keep it aligned and maybe strong enough to pull through. I don't know.
Okay, excellent point. Dave, any ideas?
No, not really. I think those are all good ideas. I think as a general rule, if I spend, a half an hour and I'm not getting any success at all, and I've utilized all my instruments, then at that point, and if the patient's a good candidate for surgery, I will just take them to surgery. I think sometimes you'll have less anesthesia time, and at my hospital, sometimes it's less expensive.
Okay, good point. Thank you. Thank you. With that in mind, leads into this final case I want to show is this was a 4-year-old dog who chewed up and ate entirely a 32-inch braided belt, leather belt. And this is, you can see on the radiograph, the distended stomach present here with foreign material inside. This is what it looks like endoscopically. He just chewed up all these braids individually. And you're looking at this saying, yeah, I could get these out, but are we better off going to surgery? And it's a difficult thing. And one of the things that I found in this case that was very helpful is that when I went in with a large rat tooth forceps, I could grasp a large number of these pieces of leather and grab and remove quite a number at each time. And so I felt there was a chance I might be able to get these out. The problem initially was that I grasped too many of them. And as I pulled that mass of leather up to the gastroesophageal sphincter, it just wouldn't go into the sphincter. So I had to learn to grasp fewer of them. Like most endoscopists, if we're getting success, we want to keep going. And that's really what we wound up doing. And you can see I was able to get all of these out. I'd like to tell you I completed the endoscopy in 30 minutes, but I did not. It was just a touch over 3 hours. So it was a very long procedure. It would have been a lot shorter, but the dog recovered and went home without having a surgery to deal with. So I want to leave you with one point, and that is when you're working on a foreign body and it is not working, don't keep doing the same thing. That's a common mistake people make, and they'll constantly sit there and use the same forceps in the same position to do the same thing and with the same result, which is failure. So if it's not working, try a different forceps. If that doesn't work, change the position of the animal. Maybe sternal recumbency will drop the foreign body and give you a better angle at removing it. If you have the luxury in your hospital of having more than one veterinarian trained for endoscopy, then pass the endoscope, because sometimes another person will just do it a little different way and they'll take it out. And then finally, remember, you got an animal under anesthesia. The longer it's under anesthesia, the bigger problem you have, the more expensive it is for the client. So it may be more efficient early in your procedure to say, too many pieces, too big, too slippery, time to consider surgery. So Christopher, I think I'm done at that point, and I'll yield 30 seconds to the gentleman from Arizona.
Let me ask you a couple questions first, Mike. Is sternal recumbency always preferred then as a rule, or is it case by case?
I think it's case by case because a lot of foreign bodies may just stay in the body of the stomach, and you don't need to roll them in that instance. Usually just the small ones. The other thing is, in examining the stomach to figure out what you have in there, how many foreign bodies, what you may use, it's a lot easier to examine the entire stomach in left lateral recumbency and to be able to blow up and distend and look in the antrum and in the cardiac region. So your initial exam is to me always better in left lateral recumbency.
Got it. Next question. Do you, and this could be for any of the three of you, do you have a recommendation for a 3 or 4 prong grasper that can take a large bite? The ones we have don't engage with the foreign body until they are almost closed. They retract so narrowly that the bite they can take makes them more or less ineffective.
I guess personally, I would agree. They tend to be ineffective forceps to me, and I don't use them very often for that reason.
Any other comments?
Well, one of the things is the prong forceps, they back into the tube. And so what you need to do is, as you can close the forceps, as you advance the prongs towards the foreign body, and you'll get a larger bite. That's a common mistake some people do.
How often, oh, one more instrumentation question. What company sells the 19mm rat tooth forceps that you mentioned?
I don't know that off the top of my head, sorry.
Okay. How often do you suspect underlying GI pathology and possible indication to take biopsies?
I think that's a really good question. You know, historically, if the animal is not presenting with chronic vomiting or chronic diarrhea, I take the foreign body out, and I do not take a full diagnostic series of biopsies in that instance. I don't know about the other panelists.
Yeah, I agree. Rarely would I do that.
Yeah, I agree.
Okay. One last question. Do you do these procedures with an assistant? Is it mandatory?
For me, no. I mean, we need a, when you say assistant, you know, we need a technician for, you know, handing you the proper instruments, taking biopsy samples off, et cetera. But for a foreign body, you certainly could do it by yourself. I think biopsy positions, it's mandatory to have a trained assistant to get those forceps in and out quickly, and then to handle the tissue specimen and get it submitted to the lab properly. But for a foreign body, probably not as necessary.
Okay. Last question. What is the risk of gastric perforation in these gastric foreign body cases?
I was going to make a joke and say it'd be higher if Dr. Matz was doing the endoscopy. I think using good technique with a wide variety of foreign bodies, it would be very uncommon. I have one case I can remember where the animal chewed up a disposable triple bladed razor blade, and all 3 of those long narrow blades were in the stomach for some period of time, and they had done virtually almost no injury to the mucosa at all.
Amazing.
So it's amazingly tough.
Yeah. Okay, thank you, Mike. And last but not least, the perforation specialist, Dr. Michael Matz.
Anyway, thanks for everybody participating. It's kind of an honor for me. I consider, you know, Mike and Dave my major mentors in my career, so it's a privilege to talk with them on this subject. All these foreign bodies came out of a single golden retriever, which is a very popular breed for foreign bodies. You know, Dave talked about the passage of instruments alongside a flexible endoscope. And not only for me, just the grasp, but I've had these uterine biopsy forceps for a long time. And sometimes they can aid you in altering, especially to me, bone foreign bodies. So this particular case here, you can see this protuberance from this bone is sort of impaled into the esophageal wall. I wasn't able really to move this, and I was afraid about causing further damage. So what I did is pass a uterine biopsy forceps alongside the flexible scope, and I was able to pinch off small pieces of this bone until I finally got enough done that you can see now how much shorter that is, and now it's rotated, and then I was able to remove it. Here's the damage, which is really quite minimal in this particular case. So again, this dog was seen on the same day that it ingested the bone, and that's a big difference maker. As opposed to this next case, this 3-year-old border terrier. This dog was seen, got into a composting pile, and was taken to a regular veterinarian. They induced vomiting and gave it activated charcoal. They continued, to manage it for a few days before they finally took a radiograph and saw this bone in the distal esophagus. So on endoscopy, we go down there and you can see this bone is eroding into the esophageal wall in a couple different places, and really try to get down there. This is before the revolutionary Twedt forceps. So it wasn't able to grab it as well as I'd like, but I tried to do this and manipulate it. It was very, very difficult. So again, up here in this left-hand corner, you can see the uterine biopsy forceps, and you can see I'm trying to gnaw a piece of this bone so that I can move it. And as we get to the one on the lower right corner, you can see I've eaten away a lot of that bone, but still with that, was not able to comfortably extract this bone. So came up with the idea of using a short-acting neuromuscular blocking agent, atracurium. And so we paralyzed the esophagus, and lo and behold, by doing that, we were able to free this bone up and remove it. When we did remove it, you can see the damage to the esophageal wall, and in a couple places here, you can see there's a small perforation in the esophagus. In this particular case, then what we did is we placed a peg tube in this dog. We put it on a penicillin derivative and a fluorinated quinolone, and treated this conservatively. As Dave talked about, it's really the way to go. And I've had a few of these, and they've done really quite well. Didn't get attention pneumothorax during this. So we managed this dogs for a couple of weeks with the peg tube feedings and the medications. And here's the same area 2 weeks later. Remarkably, the esophagus has healed beautifully. This dog did very, very well. Here's a 12-year-old domestic short-hair cat. This cat was initially seen for vomiting and regurgitation, and then progressively stopped eating and stopped drinking, actually. And so we saw it. This radiograph was taken. You can see there's a soft tissue density that's compressing the trachea ventrally. Suspect of a foreign body. Interestingly enough, in this particular cat, this cat, it was diagnosed as a kitten with a persistent right aortic arch that was treated surgically. And the comments from the previously specialty clinics was that it didn't see a lot of improvement in the motility proximal to where the persistent right aortic arch was. So with these, I always attempt to use a flexible scope and a flexible instrument. Here you can see we're passing, here's the beginning of it. We can't pass down there. Obviously, there's no room there. So I went ahead and just tried, this is with a rat tooth forceps, and doing this and getting a good grasp and gently teasing this, remarkably enough, the whole thing nearly came out. together. Sometimes these hairballs are so intertwined that it will come out as a clump. Other times it does not. So the other aspect in a different case, and I would consider doing this, here's after we remove that, was quite a bit of damage. And I don't know if this dog having this persistent right aortic arch and having maybe not as good as motility in this area actually was beneficial to us in being able to get that hairball out there as a whole. Now the hairballs really form in the stomach, and then the cats vomit, and then that's when they lodge in the esophagus. So another approach, sometimes if you're biting off and you're just getting very small pieces, in this particular case, you could use a rigid instrument and then pass a forceps through it, as Dave sort of described earlier. And then you can take multiple pieces, and you don't have to keep taking a scope in and out where you might cause more and more trauma to the esophagus, the pharynx, etc. So in this particular case, I did that. I don't have pictures of the thing, but here's the final product of taking out multiple pieces of that hairball. Next case is this 5-year-old mixed breed dog that swallowed a rib bone. And this was seen by the other internist I was working with at the time, the day before, and he attempted removal and was unable to take the bone out. And so the next day I came in, he said, I'm scheduling the dog for surgery. And I said, well, why don't you let me just take a try before we send the dog to surgery? So when I went down there, again, this is pretty long bone in this area, and to be able to orient this in such a way to get it through the lower esophageal sphincter was difficult. But interestingly enough, when we got one of our sort of used polyp snares, and sometimes that wire, I don't know if you've ever used one, and then when you push it out, it almost comes out at a 90-degree angle. And so I thought, well, maybe that would work. And so here's just an example of what I'm saying. So I got the snare and it came out sort of at a 90-degree angle. I thought, well, that'll be perfect, because if I can get this over the proximal edge of that rib bone, and then I can tighten it down at the very edge, it's almost going to be parallel to the endoscope. And that's what I ended up doing. You can see here, this is not the greatest picture in the world, but here's the bone coming through the lower esophageal sphincter. I'm right at the proximal thing. That thing's staying very parallel to the endoscope, and allowed removal of a really good size rib bone. Next case is a 2-year-old bulldog. And this owner was feeding the dog mango. And then the dog ate the whole mango pit. Mango pits are much larger than I ever anticipated. Radiographically here, when I look at this, I'm not that convinced that I could really make out a mango pit in the stomach, but with that history, we went ahead and went down into the dog. So again, this is the dog in left lateral recumbency as Mike described. So when we went in there, this is just inside the lower esophageal sphincter. So that mango's laying there. This is actually a retroflex view. This endoscope is right here. So there's no way that I'm going to be able to manipulate this or do anything with this in that position. The next one is putting the dog in sternal recumbency. The pit then went nicely into the body of the stomach, but then I was like, well, how am I going to get this thing out? So what I did is I took a rat tooth forceps just really to kind of palpate this thing. As you can see around this pit, there's still quite a bit of the fruit, and it's very fibrous. So I grasped that with the rat tooth forceps, and when I pulled, the whole thing did come, but it wasn't a purchase that was good enough that I was going to pull that through the two sphincters. So I felt like, well, maybe that has some good purchase still there. So I took a polyp snare and put it around one of the ends, and then I clamped it down. And remarkably enough, that fibrous part of that fruit there really held, it really allowed good purchase with the polyp snare. And I was able to pull this through the both sphincters. And here's that that mango pit. It's really quite large. It's one of the largest things I think I've removed from a dog. You can see after we were done, as we talked about, you always want to go down and investigate and see what damage there is. And here's that lower esophageal sphincter, and really, it's really literally no damage to that sphincter with pulling that out. This is looking at linear foreign bodies. Mike talked about cloth foreign bodies. When you go into the stomach and you realize there's some type of cloth foreign body, the first thing you want to do is get down to the pylorus and look and make sure that that foreign body is not extending into the bowel, because you don't want to just grab this and start pulling this, because you may, if it's going down the bowel, you may cause damage and or perforation. So what you want to do is get to the pylorus. You can see where this is going. It's almost plicating that antral tissue there a little bit. But what I do in these cases is I use a rat tooth forceps. I'm going to purchase this as far into this sphincter as I can, and then I'm going to gently pull that, and hopefully you'll feel give. And then what you want to do, what you want to see when you do that, as is illustrated here, is that you can see that the view of that foreign body has changed. So I know that I've made progress. Then I would go back down here again, purchase again, pull gradually until I can extract this into the stomach, hopefully. Now, when you do extract it into the stomach and you have something that's long, what you want to do is grab an end before you pull it out. You don't want to grab that in the middle, because you're going to double the thickness of that object in order to pull it through the sphincter. So try to grab the end, and that way you'll have a narrower a foreign body to be able to extract. So this was a legging of hosiery. And you can see here's the pyloric area as we finished. Again, looks quite edematous, which is not surprising considering where the foreign body was and then the process of removal. Well, some of you are probably too young to remember cassette tapes, but this was a dog that ate, amongst other things, a cassette tape. So this is the tape unraveled in the stomach. And so as I looked around here, this is actually right here, that tape is actually gouging into the gastric mucosa at the angularis incisura, and then was going down into and through the pylorus. I was able to go ahead and pass the scope into the duodenum. And in the duodenum here, you can see that tape is cutting through the intestinal wall. So I was really concerned that this would be a perforation in the end, but I was able to pass the scope down far enough that I could see the end of this cassette tape, and I was able to grab that and actually pull that all into the stomach. Remarkably enough, no air ever filled within the abdominal cavity, and this dog did quite well. Another thing that you could consider that I've done with a string foreign body in a cat is you could use endoscopic scissors, and you could cut that and allow the piece that's further down to go ahead and pass rectally, and then pull the rest of that out. So that's an option to consider. Here's going down again to look at the damage. Here's where that cassette tape was in the duodenum. This is at the lower esophageal sphincter. Again, some damage there, but this cat or this dog did really well. Last one I have is, this is 2-year-old male neutered cockapoo. This dog presented for vomiting and abdominal discomfort. We took these radiographs, and you can see again, there's a round sort of steel metal density object. And on the laboratory work we did when we had a blood gas, this dog had hypochloremic metabolic alkalosis, so classic for pyloric obstruction. So usually when foreign bodies get into the small intestine, it's very difficult to get them out. because the intestine will really suck around there, and there's not a lot of room to manipulate anything. Unfortunately, this lady told us that she was not going to do surgery. It was kind of out of her price range. And so I said, well, I'm going to give it a shot. So we went down there, and I did do an ultrasound just to show. So you can see that ball right here is acoustic shadowing below that. And then you can see in front of that in the duodenum, the fluid accumulation there. So I went down, and you can see this is a ways down into the proximal duodenum. And so what I decided to do is I thought maybe if I could pass a basket around this particular object, I could, maybe I could get this out. So I did pass it down. Now, once I got past it, I went far enough that I expanded the basket within the duodenum. And then I pulled that forward, and remarkably enough, the thing formed right around that ball. And so I went ahead and as you can see, I was tugging. This did not come out easy. And you can see some of the damage from the wires along the duodenal mucosa. But with some, constant sort of gradual tension on this and pulling, it finally came out. And so you can see the damage that's there, which really in the big picture is not problematic. So that's my last one. I'll take any questions if anybody has anything.
Okay, thank you, Mike. In the interest of time, I'm just going to ask one or two questions here.
Okay.
One is with regard to duodenal foreign bodies. Is there a rule of thumb with how far a foreign body can be into the duodenum before you'd feel uncomfortable trying to pull it back into the stomach?
I would say where this one was located is probably as far as I would ever consider attempting to do that. You're not, if they're much further down to that, there's to me no way. I've had a couple animals that I've had peach pits down there that I've been able to extract, but not very far. Yeah.
Okay. How do you decide whether to leave bones in the stomach to digest versus remove them?
To me, I guess I would look at that is if it's something that I feel like I can eat pretty easily extract, I probably would extract it. If it's something that I think is going to be complicated, I would probably leave it. Yeah.
Okay. We are 15 minutes over. I think everything went great. I want to thank you very much for this informative and entertaining presentation, Mike and Dave. Once again, I'd like to thank all of you in the audience for joining us. Our 2021 Endoscopy Talk series will be given every 2 weeks on Wednesdays. So our next talk will be January 27th, when Dr. Stephen Divers will present exotic pet endoscopy, why, and how to get started. And remember, any past talks, there are now 23 of them, can be viewed free online at endoscopytalks.com. I'd like to wish you all best of health during these challenging times. We look forward to seeing you again in 2 weeks.